So today's our topic again, acute versus chronic renal failure. So what are the causes of pre-renal, renal and post-renal acute renal failure? So-called AKI. Nowadays, definition of acute kidney disease has changed. Again, if it is less than 3 months, it is more than 3 months, it is chronic kidney disease. Some creatinine level is high, see, in your lab reports, and is persistent beyond 3 months. It is labeled as chronic renal disease, CRF or CKD. But what about less than 90 days? So less than 30 days, they say AKI, it is acute kidney injury. If it more than 1 month but less than 3 months, then you label it acute kidney disease, AKD, not CKD, okay? CKD, AKD and then AKI. So AKI 1 less, AKI 3 महीने से कम है, 1 महीने से ज़्यादा, लेकिन it is AKD, acute kidney disease, and more than 3 months it is CKD. So what are the differences? You all know that AKI means onset is over days to weeks. 1 दिन से लेकर 90 दिन तक वो AKI is label it. It is usually reversible. It is due to acute kidney injury, is due to some etiology which can be removed if treated well within time before permanent damage occurs. Then it is reversible, which is not in CKD. Okay, it is usually there is anuria or oliguria initially in AKI. थोड़ा यूरिन कम होगा या बिल्कुल जीरो आउटपुट होगा. जीरो आउटपुट मीन्स less than 50 ml in one day. So renal failure casts are absent. So there are no particular cast cells available in the microscopic examination of the urine. And urine is of high specific gravity. That means it's very much concentrated urine because only little amount is going out. High specific gravity, dialysis may be required for short duration to recover the patient, to recover from the disease, that AKI. Sometimes, most of the time, we have to order in ICU. Patient in ICU, if it is creatinine is not coming down. Silence, please, you boys. Front seat. You are more active today. What happened to you? So, when you find some patient in ICU and his creatinine is not improving, आज 1.5 है, परसों कल एक 2.5 हो गया, तो 3.5 हो गया. पेशेंट के आप देख रहे हो, पेशेंट इज गोइंग इन इडिमेटस फेज, मतलब बहुत ज़्यादा स्वेलिंग हो रही है इसके हाथ पैर पे मुंह पे. एंड देन you have to order for the dialysis. Please do dialysis for my patient. We will order the nephro department and they will decide by themselves, by ये figure says के it will need or not need, they will decide it. So dialysis may be required for short duration. So 1 to 5 dialysis, 10 dialysis may be required for the patient till he recovers from the kidney injury. Renal transplant is not, because it is acute condition, it is usually reversible, so kidney transplantation is not required in these patients. We have to wait till patients, मतलब creatinine is not improving after 3 months or more, 6 months हो गए, साल भर हो गया, then only we will decide for the transplantation. While in CKD, usually weeks to months. तो again 12 वीक से ज़्यादा हो गए उसको, 3 months से ज़्यादा हो गए, then it is CKD. मतलब creatinine यूरिया हाई है, इसका आप कितना ही ट्रीटमेंट कर लिया, it is not coming normal, चाहे 2 पे ही आके रुक जाए, but 3 months से ज़्यादा हो गए, then we will label it is due to chronic kidney disease. It is usually irreversible because of fibrosis. Because of fibrosis. The fibrosis is the after continuous insult in form of AKI. If it is not treated well, then it will induce fibrosis. Certain stimulators will come out of this one. So they will lead to the inflammation, inflammatory markers which come out, जैसे IL-6 हो गया, IL-2 हो गया, इस तरह के markers निकलेंगे, and they will induce fibrosis into that particular patient's kidney. because the disease is not improved or it is not reversed, then continuous inflammatory marker release, it will release the cytokines and they will affect the not only the vessels of the kidney but also kidney structure. उसके जो tubules हैं, there will be fibrosis. So it will become contracted. Once fibrosis happen in any organ, it is permanent. It is not reversible. So then it is labeled as a chronic kidney disease. In initial or late phases in CKD usually, or initial phase there will be polyuria. Urine आपका hyperfiltration में जाएगा. Urine output usually up to 130 ml per 1.73 square meter के फॉर्मूले से निकलेगा. तो it will increase in the initial phase. 140 तक जा सकता है, 150 तक भी जा सकता है. तो यूजुअल GFR तो 110 से 130 है, लेकिन इनिशियल स्टेज में फॉर कंपेंसेशन बॉडी किडनी will try to lead more of the urine to the process. So there will be hyperfiltration. So there is polyuria and nocturia. तो नाइट के टाइम में ज्यादा उसका यूरिन निकलता है. Casts are usually because of permanent damage. It is said that tubules will dilate because of overworking. Tubule will dilate. So there is release of broad cast, broad cells. So the cast cells which are broader in shape. These are not seen anywhere in any other kidney injury, but only in the chronic kidney disease. So broad cast may be released. So cast will be mainly present in these patients because polyuria is there and kidney has got lost the power to concentrate urine. So more of the fluid may throw it, but they have not power to concentrate. So there will be low and fixed specific gravity urine. So 1008 तक यूरिन आ सकता है. एक फिक्स रेंज होगी 6 से 8 के 1.006 से लेके 1.008 तक आ सकती है. Dialysis once start in CKD it will be frequent. Initial phase they may order once a month or 2-3 महीने में एक बार, फिर महीने में एक बार, फिर हफ्ते में एक बार. Ultimately usual is 3 times a week. 3 times a week. And if patient consumes inadvertently lot of fluid, एक दिन उसको समय में गर्मी बहुत लग रही, खूब सारा पानी पी गया, again he may land up in the emergency room with shortness of breath because of fluid overload. He may require 4 dialysis sometime. So usually repeated hemodialysis is required. Once started, you can stop only when patient undergoes transplantation. Kidney transplant हो गया, इसके बाद में इसकी frequency कम होगी. Renal transplant is usually required if available. Nowadays very strict laws for the donor. Donor should be related only blood related, but not money related. आपने पैसा दिया, किडनी खरीद ली गरीब आदमी की, तो this is not allowed in India. Nowadays strict protocols are there, and in our hospital luckily we are the second largest kidney transplant center in India. So there are strict protocols, strict आपकी कमेटी बैठती है 6 दिनों की. They decided this patient required transplant, and जो donor है that is not related to that is blood related to the patient, and there is no involvement of money transaction for the purpose of transplant. So AKI की definition क्या होगी? We should know that any rise of creatinine of 0.3 milligram. Suppose patient आया, आपने last week उसकी creatinine कराई और it was 0.6 only. अब next visit पे आपके पास 0.9 पे आ गया. That means patient if within 48 hours उसका 0.3 से ज़्यादा बढ़ गया, then it is AKI. This may be of 2 forms again, oliguric and non-oliguric. Oliguria means patient का renal output is less. It is less than 500 ml in the 24 hours. If it is more than 500 ml, then it is non-oliguric. मतलब creatinine बढ़ रहा है उसका patient का, लेकिन output भी अच्छा आ रहा है. Then we will label that as a non-oliguric acute kidney injury. Etiology according to the lesion. Again, it can be pre-renal, renal or post-renal. So what is the importance? We will just see just now. So pre-renal is involved. That means patient का renal perfusion is involved. यानी उसको कम blood supply हो रही है. We will see just now what are the reasons. Renal means renal में 3 part, kidney में 3 part important है histologically. Glomeruli where the urine is formed, tubule through which the urine passes, and interstitium that is around the tubule, the part of the kidney which is supporting the tubule and going right into it, that is interstitium. If it is at fault, then interstitial nephritis we will label it as. Post-renal again diseases which are involving the after kidney, structures involving after the kidney. That means urine has formed, kidney is not at fault, urine is forming and going through the ureters and then through urethra. If there is any obstruction in urethra or ureter, then we label it as a post-renal kidney injury. So staging of AKI. So this will give you impression how serious is the patient. So at what level you should treat it and what rapidity you need to treat the patient. So simply to simplify, 1.0 or 1.2 up to 1.4 sometimes field laboratory level. 1.4 creatinine is normal range. अगर पेशेंट का क्रिएटिन 1.5 से लेकर 2 तक आ गया, इट इज स्टेज 1, 2 से 3 आ गया, स्टेज 2 3 से ज्यादा हो गया, स्टेज 3 है उसकी. अब बाई यूरिन आउटपुट इफ लेस देन हाफ ml पर आवर फॉर 6 to 12 आवर, यहाँ आधे दिन या 6 घंटे 12 घंटे तक उसे पेशाब हाफ ml पर kg से कम आ रहा है. जैसे 50 किलो का आदमी 25 ml ही आया, उसको 25 ml से भी कम आ रहा है, देन वी लेवल इट एक्यूट किडनी फॉर 6 to 12 आवर. ये 12 घंटे से ज्यादा तक उसका यूरिन आउटपुट लेस देन हाफ ml चल रहा है. 25 ml पर आवर के हिसाब से 12 घंटे के 24 घंटे तक चल गया, 12 घंटे से ज्यादा चल गया, देन वी लेवल इट स्टेज 2. एंड if it is less than 0.3 ml per kg per hour for 24 hours और एन्यूरिया हो गया उसको 12 घंटे, then we label stage 3. इसकी सीवियरिटी स्टेज 3 है. बड़ा डिस्टर्बेंस होता है. जब हम पिक्चर्स जाते थे ना, पीछे को 2 महिलाएं बात करती थी, बहुत डिस्टर्बेंस लगता था. वो एक महिला दूसरे को स्टोरी सुनाती रही, देख अब ये नहीं ऐसा हो गया है, बहुत इरिटेशन होता था. पैसे दे के जाओ फिर भी आप पिक्चर का मजा नहीं ले पाओ, है ना. तो आप सभी लोगों ने पैसे दिए पढ़ने के लिए, है ना. अगेन फॉर दिस वन डिस्कशन, राइफल क्राइटेरिया और अलग अपन राइफल क्राइटेरिया. राइफल रिस्क, इंजरी, फेलियर, लॉस ऑफ किडनी टिश्यू एंड ESRD, दैट इज एंड स्टेज रीनल डिजीज. अगेन दिस क्रिएटिनिन 1.5 तक, 2 तक, 3 तक हो गया, ये 4 वीक से ज्यादा हो गया, लॉस ESRD मोर देन 3 months. Okay, again urine output criteria almost same. So that is rifle. Anything you can remember, दो आप criteria याद रखते हैं, 2 means 2 आप classification याद रखते हैं, then you are very good. कम से कम एक criteria आपको अच्छी तरह याद होगा, because this is very common question during a theory exam as well as in practical if you get AKI patient like that. So causes of acute renal failure. Pre-renal causes intrinsically that means renal causes pertaining kidney disease. Post-renal causes when that means kidney is okay but urine is getting obstructed at somewhere, so that is giving back pressure to the kidney and urine output is hampered. So pre-renal is related to vascular. Hypovolemia हो गया, vascular compartment में patient को hypovolemia हो गया. That means there is not enough fluid in the artery supplying the kidney. So hypovolemia. Now causes may be, we will see later, और hypotension हो गया किसी भी कारण से. Then again patient को pressure ही नहीं उसमें vessel में, तो सप्लाई नहीं हो रही है ब्लड की टू द किडनी, तो परफ्यूजन नहीं है तो उसमें फिल्ट्रेशन नहीं होगा. लॉस ऑफ ऑटो रेगुलेशन, अब दोनों चीजें हैं उसके, हाइपोवोलीमिया भी नहीं है उसके, हाइपोटेंशन भी नहीं है, स्टिल पेशेंट का यूरिन नहीं बन रहा है, क्यों? बिकॉज ऑफ लॉस ऑफ ऑटो रेगुलेशन। वहीं सिर्फ ग्लोमेरुलाई पे ही इसकी प्रॉब्लम हो रही है। इट कैन बी efferent arteriole or efferent arteriole due to drugs like NSAIDs and RAS blocker, that renin-angiotensin aldosterone system blockers. Abdominal compartment syndrome, we will just say that any abdominal trauma which is causing blood loss into the peritoneal cavity, if it are any fluid which causes tense ascites like thing, it may cause renal compartment because it will compress the kidney vessels and there will be not enough perfusion to the kidney. Again, renal artery stenosis, local factor of the kidney artery, that means stenosis is there and it is not supplying blood in the full quantity because of obstruction. Just like in what we see in angina, in our heart circulation, there is atherosclerosis, there is stenosis somewhere and blood supply is not full to the heart. Similarly in the kidney, if there is renal artery stenosis, there will be hypoperfusion of the kidney. So heart failure and hepatic cirrhosis, we will see just now how they lead to it. So intrinsic, if tubules involved, glomerular involved and interstitial is involved. So tubular ATM is very common. Ischemic or toxic ATM quite common. Toxic due to drugs. So any contrast study to the patient, आपने किसी पेशेंट की CCT एब्डोमेन करानी है, पल्मोनरी एंजियोग्राफी करानी है, कोरोनरी एंजियोग्राफी करानी है, या सेरिब्रल परफ्यूजन स्टडी करानी है, दैट मीन सेरिब्रल सर्कुलेशन देखना है आपको, एंड यू इंजेक्ट द डाई एंड दीज डाई आर आयोडीनेटेड बट दे आर हाइपोरोस्मोल, दे विल cause some damage to the kidney because excretion will be of the dyes through kidney. So these are hyperosmolar dye and they already patient's creatinine is high. So more than 1.7 or more than 1.8. Your patient, they will refuse. They will ask first creatinine report iski dikhaiye hame, then we will go for the contrast study. So if it is higher side, they will refuse because if you load the patient with a contrast, it is causing more dose, damage to the kidney and patient may go into more severe renal failure. Vascular, that is glomerular nephritis. Glomerular nephritis 4-5 तरह की जैसे होती है, मिनिमल चेंज डिजीज हो गई या फोकल सेगमेंटल नेफ्रोस्क्लेरोसिस हो गया, रैपिडली प्रोग्रेसिव ग्लोमेरुलर नेफ्राइटिस हो गई, ये होगी ग्लोमेरुलर नेफ्राइटिस और डिस्प्रोटीनिया, माइलोमा प्रोटीन जैसे हो गए, इफ दे ऑब्स्ट्रक्ट द glomerular this one vessel compartment, they may cause blockage of the arteries, smaller arterioles, and they will cause ATM or this one intrinsic renal damage or microangiopathy, that is hemolytic uremic syndrome and TTP, the thrombotic thrombocytopenic purpura. These are two common conditions, not interrelated but quite similar conditions with few differences. If it is present there, they will cause damage to the kidney. Interstitial nephritis, also called allergic nephritis, so and also pyelonephritis. If there is interstitial is involved, it will lead to AKI. Postrenal urethral obstruction due to prostatic hypertrophy. It may be benign, it may be malignant. So it will cause urethral obstruction and back pressure से kidney compress हो जाएगा इसका, तो यूरिन बन रहा है इसके, किडनी में कैपेसिटी है लेकिन it is not coming out. So chronic obstruction will lead to renal failure. If it is not corrected in time, it will lead to permanent damage. So and urethral obstruction, bilateral urethral stones हैं, either in the pylorus or in the uretus. So this will lead to chronic obstruction to the outflow of the urine, and then they will cause back pressure and it will cause the renal failure. So previous azotemia, I told you hypovolemia due to any cause. Patient के diarrhea हो रहा है, decreased fluid intake due to any reason, or patient is having orthostatic symptom. लेटा हुआ पेशेंट ठीक है, जैसे ही वो खड़ा होता है बाथरूम जाने में उसको चक्कर आते हैं, ऑर्थोस्टेटिक symptoms are there. Low cardiac output due to either heart failure, congestive heart failure, or due to acute MI. So any loss of tissue of the heart due to the compromised circulation, this will lead to decrease in the cardiac output. Decrease in cardiac output तो pressure ही नहीं बनेगा किडनी के पास में उसका. On examination, these patients show dry mucous membrane. Oral mucosa will be dry. Skin will be very turgor is lost. उसकी elasticity खत्म होगा. पेशेंट का पिंच करोगे ऊपर से छोड़ दोगे, it will not come normal within immediately. It will take some time. 15 to 30 seconds के बाद में that skin will become normal. If there are orthostatic hypotension, that is patient का supine BP और बैठे हुए और खड़े हुए BP, systolic BP difference is more than 20 and diastolic BP difference more than 10, then in label it is orthostatic hypotension. It can be due to hypovolemia. If CVP is less than 8, in these patients CVP is less than 8 cm, which is normal for normal range, 8 cm of water. So in pre-renal azotemia, there is low cardiac output, as I told, drop in effective circulating volume, although there is fluid overload in the body, but there is no effective volume because of the low cardiac output. Sympathetic and neurohormonal factors are stimulated, so RAS is activated. Renin, angiotensin, aldosterone system is activated, which will cause sodium retention, ADH secretion to conserve the. उनको तो हाइपो सेंस हो रही है कि वॉल्यूम की कमी है, तो ADH will be secreted. So more water absorbed and sodium will be conserved. So sodium भी increase हो रहा है, water भी आपका conserve हो रहा है, तो more edema is developing there. Also there is increased urea absorption as compared to creatinine. In this patient acute renal failure में क्या होता है, creatinine 1 से तो 1.5 हुआ है, लेकिन यूरिया जो 40 से लेकर 80-100 हो गया, but more than double. Creatinine still 1.5 times. So acute renal failure की खासियत होती है कि यूरिया rising very fast rather than the creatinine. While in the chronic renal failure, creatinine is increasing slowly, but it is usually more than the urea rise. So this is just for showing you. This macula densa, it sends the low fluid in case of pre-renal azotemia. So macula densa will sense low fluid flow and low sodium concentration, and they'll secrete the renin, and they'll release it into the circulation. From this level will release the angiotensin level in the blood, and it will be converted to angiotensin 1, and by AS, that is angiotensin converting enzyme, this will be released from the lung, and it will cause change of angiotensin 1 to angiotensin 2. It will again stimulate, this angiotensin 2 will stimulate the adrenal cortex to secrete aldosterone. This aldosterone, what will cause? Conservation of the sodium and increase in the H2O, because they will secrete also ADH. So through aquaporins, this water conservation is there. What is aquaporin? These are cellular membrane structure that selectively passes water. These are water channels, proteins. This is aquaporins. So this aquaporin is a kind of protein actually, channel protein. It forms a barrel-shaped structure, and through which there is a hole. Through that the water moves very freely. this is more than the diffusion or osmosis. So that is the importance of evaporance. So pre-renal factors, again, in case of hepatorenal syndrome, patient is suffering from the liver failure, decompensated liver failure, and they suddenly go into renal shutdown. Suddenly urine output one day it will decrease, and we label it as a hepatorenal syndrome. So what are the precipitating factors for this HRS? The spontaneous bacterial peritonitis, that is infection of the ascites, collected fluid into abdomen. That in ascites they develop some infection, that is called SBP. In these patients there will be fever as well as pain in the abdomen, also tenderness of the abdomen. The three features will define the SBP. लार्ज वॉल्यूम पैरासिन, आपके पास पेशेंट आया, आपको लगता है कि 20 लीटर से ज़्यादा पानी है, वो उसका 5 लीटर आज निकाल लो. You should not do that, because suddenly shift of the fluid out of the body, it will lead to the pre-renal, that is hepatorenal syndrome. Aggressive diarrhea, again आप नहीं चाहते निकालें पानी, पर लेसिक्स तो उसको बढ़ा के दे दो. ओके, वन से डे दे रहे तो इसको 3 बार कर देते हैं, खूब यूरिन निकल जाएगा, पेशेंट हल्का हो जाएगा. दैट अगेन may lead to hepatorenal syndrome. Or sometimes there is GI hemorrhage. Hepatic condition है, there is esophageal varices. Suddenly if they burst, say 500 ml of blood is lost through vomiting, it is secreted, it is gone into the stomach. This will again their shift of the volume. It may lead to hepatorenal. Suddenly इसका प्रेशर कम हो गया तो किडनी में भी ब्लड नहीं जा रहा सप्लाई, तो it will lead to hepatorenal syndrome. So this is treatment we'll discuss later on. In heart failure again, pre-azotemia is there, it will lead to renal syndrome, this renal failure. Just because volume, heart is not able to pump the blood at a desired pressure. तो किडनी में आपके प्रेशर बनेगा ही नहीं, it will not reach the glomeruli forcefully. So less amount of filtration is there. So whenever we treat the heart failure in such patient nicely, so ventricles empties or unloads very well, and it will improve the ventricular function as well as renal perfusion will increase. In hepatic failure, what happens? Splenic vasodilatation, venous pooling is there in the abdomen. So it will diminish effective circulating volume is there. Though the patient is already overloaded, but effective volume in circulation is less. So this will lead to this RAS, we just now saw it. RAS is acute and ABS secretion is there. So a patient may go into hepatorenal syndrome. And serum creatinine lies more than 1.5, which may not improve with the albumin transfusion or diuretic therapy of 48 hours. So this is again hepatorenal syndrome. And this is very important for you to understand and remember why you should keep, what you should keep in the mind before prescribing NSAIDs as this ACE inhibitors. So NSAIDs क्या करती हैं? Afferent arteriole of the glomeruli. Afferent artery उस थोड़ी dilate रहनी चाहिए पेशेंट की. Afferent, that is carrying the blood to the glomeruli. तो उसमें प्रेशर अच्छा बनेगा उसका. And this is helped by the prostaglandins. Prostaglandin secretion causes vasodilatation of the afferent arteriole. If we give NSAIDs, non-steroidal anti-inflammatory drugs, it will decrease the prostaglandin. That is anti-inflammatory drugs, it will decrease the prostaglandin. And prostaglandin का secretion कम हुआ तो उसका vasodilatation कम हो जाएगा afferent arteries का. तो blood supply will be less to the glomeruli, and it may cause acute renal failure. Similarly, efferent artery should remain constricted little bit so that pressure in the glomeruli is more. अगर ये dilated रही तो blood जैसे आया afferent से सीधा पास, तो प्रेशर उसको रोकने वाला कोई नहीं, तो it will pass the blood without any hindrance. So there is no effective pressure in the glomeruli. तो उसका कॉन्स्ट्रिक्ट करना बेटर है। लेकिन इफ यू आर प्रिस्क्राइबिंग एस इनहिबिटर्स, इफरेंट आर्टरी को वो डायलेट कर देते हैं। दीज आर वेरी डायलेटर बट टू द इफरेंट साइड, अगेन दे मे इंड्यूस acute renal failure. ACE inhibitor may cause acute renal failure by dilating the efferents. So a patient is, if hypovolemic, hypotension, do not prescribe ACE inhibitors and NSAIDs. This is the take home message. if patient को कहीं से भी hypovolemia हो रहा है, hypotension में, don't prescribe ACE inhibitors and NSAIDs. This may lead to acute renal failure. So first, patient is hypovolemia में अगर BP भी है इसको, first give some fluid so that the circulation is okay, not hypovolemia, and then you can prescribe the ACE inhibitors. Post-renal azotemia, as I told you, any BPH, benign prostatic hypertrophy or malignancy, prostatic cancer or any growth in the bladder neck, it will obstruct the flow of the urine out and it patient may go into acute renal failure. So इसमें एक बड़ा सिंपल सा होता है, ये lead obstruction and patients renal failure will improve. So rest of the things we'll take in the next lecture.